Hello, everybody. Welcome to class today. Before we get started today, I'm going to be talking about interpersonal violence. And I just want to give a trigger warning for anyone in the class who feels like they might need to just kind of bow out for a little bit to take care of yourselves. Feel free to do whatever anybody needs to do. Before I start with my lecture, I want to play this clip of Alexandra Ocasio-Cortez, AOC. She's talking about, she's a Congress woman, and she was in the Capitol when it was stormed during the insurrection recently. But she's talking about the fact that she's a sexual assault survivor and how oftentimes trauma compounds trauma. So let's go ahead and give a listen. If I can get, it's not working. Why are you not working? There we go.
These are the same tactics of abusers. And I'm a survivor of sexual assault. And I haven't told many people that in my life. But when we go through trauma compounds on each other. And so whether you had a negligent or, a neglectful parent, or whether you had someone who was verbally abusive to you, whether you are a survivor of abuse, whether you experience any sort of trauma in your life, small to large, these episodes can compound on one another. My story is not the only story, nor is it the central story. It's one of many stories of what these people did in creating this environment. And these folks who are just trying to tell us to move on are just like pulling the page. They're using the same tactics of every other abuser who just tells you to move on, of that man who touched you inappropriately at work, telling you to move on. Are they going to believe you? Or the adults who, if they hurt you when you were a child and you grow up and you confront them about it and they try to tell you that what happened never happened. Or, the countless people who tell women and non-binary people that, they're constantly trying to get attention just for existing and just for saying that they exist. Like, these are the tactics of abusers. And this is at a point where it's not about the difference of, this is not about a difference of political opinion. This is about just like basic humanity.
So obviously she gives an emotional recount of the fact that her sexual assault history and then being stormed in the insurrection. I remember just hearing about when that started and it kind of broke the news. I was like, they're going to go after her, aren't they? Because she certainly has a lot of enemies because she's so outspoken. Comments, questions, anybody on that? Okay. Let's go ahead and get started. I'm trying to get my PowerPoint just right so I can start it. Okay, everybody can see the PowerPoint? We good? Okay. All right. So let's define interpersonal violence. It's aggressive behavior intended to cause harm, and there are different levels of severity. So moderate would be somebody who gets pushed, grabbed, slapped, and here's the prevalence of that. The more severe forms of interpersonal violence would be more physical, choking, kicking, punching, hitting, and getting threatened with weapons. That's a little less common. Women represent 70% of murdered spouses. So when spouses are murdered, you're more likely to see that affecting and killing a woman. Women are 10 times more likely than men to be assaulted by an intimate partner. And of the women, I'm trying to move my bar around here, of the women who are assaulted each year, 27% end up receiving medical care and 15% end up hospitalized because of their assaults. And we'll talk at the end of the lecture today about ideally how healthcare providers are intervening when these women are seeking healthcare. Okay. I want to give you a little bit of local data just to kind of put this into context. Many of you know that our PsyD program, our clinical program, we're really trying to emphasize training individuals to go and serve in rural areas. And rural areas definitely have some different types of issues compared to more suburban or urban geographical areas. This was a study that me and my colleagues conducted. And we used the Youth Risk Behavior Surveillance Survey, the YRBS, which is developed by the Center for Disease Control. And we gave that survey, you all probably took that survey when you were in high school, if any of you can remember that. It asked you about all kinds of different risk behaviors. So we gave this survey to 2 of the local high schools that are considered to be rural, and that is Allegheny High School and Ashe County High School. And we asked these teenagers if they had been victims of dating violence, so physical dating violence. And we asked these teenagers if they had been victims of rape. And we looked at how either the dating violence or the rape, or if they reported both had occurred to them, how that was associated with other risk factors. And we compared those individuals to individuals who had neither a dating violence history nor a rape history. And what we found, we were kind of overwhelmed with the numbers. And I'm not going to expect you to know these numbers. I'm just going to put a couple of these into context for you. We know when we asked them about rape, there were definitely more females compared to males in both of the high schools who were reporting being victim of rape. This is pertinent to Emma Albertino in our class. When we asked them if they had been electronically bullied, so bullied on social media as an example, here's the rate of females compared to males who were reporting that form of bullying, and again, in both high schools. And I'm not going to go through all of these, but I just wanted to give you an idea of there are definitely certain types of violence directed at women that are more common in girls and women than are in boys and men. So then what we did is we ran what's called a relative risk ratio, and we categorized, again, these women, when they reported both, it's the dating violence and the rape, but then in some situations, it's just one of those categories of interpersonal violence. And then we looked at the association if they had been a victim of this form of violence versus none of the violence. And what we found, and what a relative risk ratio tells you, is this is times the risk. So these girls, these teenage girls who had experienced both forms of interpersonal violence had 8.8 times more substance abuse than these teens that had not had any of that violence. They were 5.9 times more likely to experience depression if they'd been victims of both. 4 times more likely to have developed a suicidal plan if they had been victims of both. And just to give you a little context, we had in recent years, we had a suicide with a female in our local rural high schools. And one of the hypotheses was that there was social media, electronic bullying going on for this particular girl. 3.7 times more likely to experience suicidal ideation, and then on and on and on it goes, kind of where we've parsed these out. But I do want to focus on something down here at the bottom, the grades. 2.2 times more likely to have had a suicide attempt that required medical care. That's how that's defined on the YRBS if they'd been a victim of a rape. But I do want to focus a little bit on the lower grades. 1.2, it's not really a high relative risk ratio, but it is higher. The gals with the lower grades had on average a C GPA, and the gals that had not been victims of violence had on average a GPA. But what I want to go into is I want us to kind of look at how this might unfold. An A GPA is going to result in a different career path for most rural gals relative to a C average GPA in college. Does that make some sense? Okay. The A averages, if they've got the opportunity and they have the resources, they're a lot more likely to go to community college, a lot more likely to go to a four-year college than, say, the C average students who are likely, they may go and get an associate's degree, but they're likely not going to go on to a four-year college. Now, fast forward this, my friend, Dr. Jody Plaha Jones, who's at ETSU, she's a pediatric psychologist, and she has found in rural areas the best predictor when a child has a disability. So it could be something like ADHD, it could be autism. The best predictor of that child getting to a pediatrician's office and that pediatrician being alerted about a concern so that the kid gets assessed for that disability is mom has a college education, a bachelor's degree. It didn't matter if dad had a bachelor's degree, but if mom had a bachelor's degree, that child was much more likely to get to that pediatrician's office and that mom saying, I'm concerned about my kid. And that's a valuable thing because you want to make an accurate diagnosis so a child can get the services that he or she needs. Okay. So when I think about this stuff, and part of the reason why I've been interested in interpersonal violence is the thing that upsets me the most is that oftentimes, and these are teenagers in high school, that oftentimes interpersonal violence directed at a teenage girl changes their life trajectory. Okay. And that is very sad to me, very, very sad. And I know from working with clients in therapy that it takes a lot of guts and a lot of motivation for individuals to go to therapy and to heal from their interpersonal violence background and deliberately change the trajectory of their lives. That is hard to do. That is hard for individuals to do. And so I'm very honored when I get to work with people in therapy and help them with that. Any questions here or comments? Okay, in another study that we did, many of you have had, this is Dr. Mary Ballard, Dr. JP Jameson. We did an additional study on these rural teens. And in this particular study, what we looked at were if teens were LGBT, actually the YRBS doesn't have Q, so it's technically LGBT teens relative to teens who do not identify as LGBT. And we looked at risk factors. And in this situation, we found their suicide risk was 5 times higher being LGBT than not. Being a victim of bullying was higher. Being a victim of school violence was almost twice as high. Engaging in drug abuse was 1.5 times higher, and then risky sexual behavior about 1.3 times higher. This means it's tough being LGBT in a rural area. I mean, it can be tough in a suburban and an urban area. One of the things that we also found is that these local high schools do not have LGBT support groups. And the research literature suggests that having some type of support group where kids can go join a club, meet other individuals that are similar to them or struggling with similar types of issues that they are, that mitigates risk, that can really buffer risk. But a lot of these rural schools don't have them because they're considered to be risky or inappropriate, particularly when you're in some counties, some rural counties that the majority of individuals identify as being fundamentalist Christians, as an example. Questions here? Comments? Okay. Some of the theories of what causes etiology means cause of what causes violence. Some of the psychological theories are that these perpetrators or batterers have personality disorders like borderline or antisocial personality. Oftentimes they're involved in drug and alcohol abuse, or depression that evidences itself as irritability and a need to control an environment. Some of the social psychological theories, when children view violence in their home as children, they oftentimes develop this notion, this idea that it's normative, like that this is how conflict gets managed, or a hierarchy gets established. And if they don't know like we don't know what we don't know, how can we know what we don't know, right? And so oftentimes witnessing it as a child makes it seem kind of like this is how it is, this is normative, and then more likely to be accepting of violence directed at them as an adult, or more likely to perpetrate violence as an adult when they have witnessed it as children. And again, when I get it, we call this the circle of violence, and y'all have probably heard of that before. But it does seem to change a trajectory of people's lives. And again, it can be really challenging to break out of that circle, that vicious circle that is occurring across generations. Some of the sociological theories, the idea that culture supports a power differential, that it's acceptable particularly for men to use force or to use control to keep women in line. So that would be some of the sociological theories. And then again, I'm not going to banter too much on the fundamentalist Christians, but oftentimes there is a belief in those families that husband is supposed to submit to God, but wife is supposed to submit to husband. And that kind of establishes that hierarchy of power. Okay, I found some really interesting research on what we think is what we know to be going on, but again, the data hasn't quite caught up to this, but we know from looking at previous pandemics, particularly looking at MERS, SARS, and Ebola pandemics, not all of those studies necessarily conducted in the United States, but conducted where those pandemics were those epidemics were happening. We know that domestic violence tends to increase during a pandemic. Okay. And in this Center for Global Development, Peterson and all, lead author in this study that was published this past year, they were appointed to a gender and COVID-19 working group. And what they were doing was looking at the previous scientific literature, as well as advocating for what they would say, using science for what they call a feminist informed pandemic response. Okay. And what they were looking at was violence against women and children, and what were some of the dynamics that play out during a pandemic that ends up increasing violence directed at women and children. And again, some of this is based on previous research from previous outbreaks. Some of this is advocating for data collection right now. We definitely know anecdotally that domestic shelters are hearing more concerns. We're hearing from people, but we don't have the scientific studies yet during our pandemic, if that makes some sense. We know that quarantine and lockdown tends to exacerbate if there's economic insecurity or poverty related stress, particularly if one adult or adults in the home lose their jobs because they have to stay home in quarantine and take care of kids. We know there's more exposure to relationships that are exploiting, an inability to escape abusive partners that has been more challenging. And that's one of the things that we do when we're working with a individual who is a victim of domestic violence. We have a safety and an escape plan in place. And that could even include things like keeping a bag hidden in their car that has, food and water and toothbrush and extra clothes for them and their kids, things like that. So difficulty escaping. This is really sad. Earlier onset of sex in female teens, and based on some of the previous outbreak data, oftentimes teenage girls are put up for sex in order to trade resources. So they are trafficked in their homes in order to get money, to get food, to get resources from the men that are using them. We have seen an increase in pregnancies during a pandemic, and we could look at that lightheartedly and be like, well, yeah, people at home, they got, and they get bored, they've got more time to snuggle up and get busy. But unfortunately, what that means for women, we tend to see when there's ongoing domestic violence happening in a home, a pregnancy actually increases the frequency and the severity of the violence. And one of the theories about that is that oftentimes a perpetrator, the mom is giving all this attention to her pregnancy and there's excitement about having a baby, but the perpetrator oftentimes feels like her attention, her excitement and her love and her attention is going to be taken away from me. And that is very threatening. And so unfortunately, pregnancy is a risk factor for an increase in violence when it's ongoing in the home. And then we get into some really controlling kinds of behavior of perpetrators withholding safety devices. So not allowing a woman to have a mask when she goes out to the grocery store, withholding money, not allowing her to get vaccinated. We've seen this in some previous pandemics and think it's probably going on worldwide now. And more women, we talked about in a previous lecture, are frontline healthcare workers. Female healthcare workers are a lot more likely than male healthcare workers to be assaulted and be a victim of violence in their workplace. Okay, whether it be other doctors or nurses attacking them, whether it be patients attacking them. But we're seeing here a theme that women and children are more likely to be increased violence during a pandemic. Any thoughts or questions there? I donate on a regular basis to Oasis, which is our local domestic shelter, but I have, it's been easy to save money during a pandemic. You can't do anything. You can't go shopping, you can't travel, get an airline flight anywhere else. I have been especially diligent about donating more to Oasis during this pandemic, because I know I have friends that work there who have said their volume has increased. Okay, so let's kind of break down the two types of domestic violence. Common couple violence is more likely to be, based on an argument. It tends to be more occasional. The aggression, whether it be verbal or physical, tends to go both ways. It's bidirectional between partners. And it's usually, trying to win an argument, win a situation, win a debate. And it doesn't tend to escalate. It's just kind of situational and occasional. Patriarchal terrorism as a form of domestic violence is much more serious. The aggression is usually unidirectional, one partner directing it at another partner, but not bidirectional. And the reason why it tends not to be bidirectional, it'd be really dangerous to reciprocate. In a lot of situations, women trying to de-escalate a situation and not fight back. It tends to start out milder and then escalates over time in frequency and severity. These are more likely to be women who flee to shelters. And then the threats that are made within the home, there tends to be intimidation, coercion is used, emotional abuse, calling people names, engaging in gaslighting behavior. I think many of us have heard of that term, gaslighting more recently, which would be a form of communication where the perpetrator makes the victim feel like her reality is not her reality. And it oftentimes in gaslighting, it starts to make a person in that distrust of reality start to feel crazy. Okay, so an example would be perpetrator lies or says something, and then later on perpetrator is like, I never said that, I never did that, you're imagining that, you must have dreamed that, stuff like that. And where they end up over time sort of feeling like, oh my gosh, I'm unstable or I'm feeling crazy. And then that oftentimes strips women of their agency. It strips them of their ability to go, wait a minute, this isn't right, and I need to get myself out of this. It's more like, oh my gosh, if I weren't so crazy and unstable, maybe things would be better. Okay, so it's a really awful form of emotional abuse. Being isolated, and again, during the pandemic, this has happened even more. But oftentimes what perpetrators will do, I've been watching Grey's Anatomy again recently. And Joe, if you all know Grey's Anatomy, Joe was a victim in a previous marriage of patriarchal terrorism. And one of the things that she said, that she and then the new woman with the dude talked about, is that a perpetrator encouraging individuals to not spend time with friends or not spend time with family. And so this over time, this isolating them in the home where they can totally control them, and information about what's going on in the home doesn't leak out to other people. Minimizing, denying, blaming, again, that's some of that gaslighting kind of stuff. Using children, so making threats like, if you don't do this kind of thing, I'm going to hurt the kid, or I'm going to take the kids away from you because you're so crazy, you're not a stable parent, that kind of really awful kind of abusive manipulation. Male privilege, this kind of like males deserving certain things, like I don't need to have to clean up the kitchen, or I don't need to have to do the laundry, that kind of stuff. And then the economic abuse would be withholding resources, money, things like that. So you can see how, one of the biggest questions that is oftentimes asked when a woman is in a home and she's a victim of domestic violence is, why don't you just leave? Right? Y'all have heard that kind of that stereotype or that myth. And when you start looking at the psychology of what is going on here, there are a lot of reasons that actually forces that keep that woman in that home and prevent her from leaving. And let's talk a little bit more about, we'll talk a little bit more about those. I think I've got a slide in here somewhere with psychological factors. Let me pop quickly. Maybe I didn't, or I updated it and I didn't update this particular PowerPoint. Okay, let's talk about those other psychological forces a little bit here. One is that it oftentimes, the violence starts out low and then it escalates over time, and we call that gradations. It happens in gradations. It happens over time and kind of slow enough that the woman doesn't have, okay, the line is drawn here. Does that make some sense? Like the line is drawn when you hit me after you've been emotionally abusing me. The gradations, we even saw that in the classic Milgram experiment, where the subjects in Milgram's experiment would go up these gradations in shock. If y'all remember that. And remember, they weren't really shocking people. It was set up to make it look like they were being told to administer shocks, and they were administering the shocks in what they thought were higher and higher and higher levels. But again, because it was happening in gradations, like, well, I just moved my shock level up a little one, and I just moved my shock level up another one, and I just moved it up another one. It's hard psychologically for people in that situation to draw that line and go, okay, well, when we get to 50 volts, I'm out, that kind of thing. Same thing is happening in these relationships. It's going on in gradations. And oftentimes women are not able to see, like, wow, okay, look at how much more severe it's become. Another interesting thing that happens that's very psychological is the honeymoon phase. And y'all probably heard a little bit about that. That would be where, after an episode of violence, perpetrator gets in there and apologizes, and then is very sweet and caring and maybe brings gifts. And there's the honeymoon and then there's usually promises, I'll never do this again kind of thing. And that honeymoon period we consider to be intermittent reinforcement. And intermittent reinforcement is the most powerful form of delivering reinforcement that will keep people reinforced or happy, and keeping women in that situation. That makes some sense? And so it's sort of like there's this like episode of violence, and then there's a honeymoon, and an episode of violence, and then there's a honeymoon, an episode of violence and a honeymoon. And then that intermittent reinforcement oftentimes keeps them in that relationship. Okay. Most of us, as an example, if we were out on a first date with a potential partner, and that person called us names and hit us, we would probably be like, oh, I'm done. I'm done. But once individuals get so far deep into this situation, they're getting that intermittent reinforcement. It's happening in gradations. There's a lot that's going on. And then the more successful the perpetrator is in controlling this individual's emotions, controlling their financial resources, that type of thing. If there's children involved and they're the only ones that are supporting the children financially, these women are getting dug in deeper and deeper and deeper. Okay. And I want us to have some sympathy and some understanding that it's not as simple as, why don't you just leave? Okay. Add to that, violence increases and the threat of death increases when a woman makes an attempt to leave. Okay. So she's actually putting herself at more risk and putting potential children in the home at more risk if she does make a leave attempt. Okay. Add to that, we've been hearing a lot, certainly over the years, about racial violence from police officers. Police officers really tend to dislike dealing with domestic violence cases. They are a lot more likely to get harmed themselves. They are a lot more likely to write off domestic violence as, well, it's a love spat, and it's not my business to get involved in a love spat. And we're seeing, certainly there are a lot of interventions nowadays trying to sensitize police officers to being more systematic and more sympathetic and systematic in how to intervene. Have you all heard I think this is brilliant. It's really clever. And if you know anybody in a situation like this, make sure they know about this. But if you call 911, and have y'all heard this? You call 911 and instead of like saying, my partner is being violent and I'm scared for my life, if you call up 911 and order a pizza and say, some of you are nodding your head, I would like a pepperoni pizza with vegetables delivered. Here's my address. They know in the 911 stations that that is a call for help. And it's a call for quiet help. So it's not like, they're going to do the whistles and all that kind of stuff and roll in there. They know that that is a woman calling and saying, I need help. I need security here. Questions, comments? Okay. Okay, which women are at risk? Younger women tend to be more at risk than older women. Women who are unmarried or cohabiting tend to be more at risk. Pregnancy, we've talked about before. When I was on my internship, in one of the grand rounds that I attended, it left a mark on me forever. It was an OBGYN. He was a male OBGYN. I don't recall his name, but he has spent his career researching and going around and giving grand rounds and giving talks about how to recognize violence in women. And one of the pictures that he showed during his presentation was an ultrasound of a fetus with a broken femur. So its leg was broken in utero. And what had happened to this woman is her husband had taken a baseball bat and hit her in the abdomen and broke that baby's leg inside her uterus. And it was just like, whoa, that's horrible. And again, so there's a bit of an age confound with pregnancy. You're not going to see pregnancy, say, in 60-year-old women. But again, it tends to escalate when it's ongoing in those situations. And then again, that circle of violence, if these individuals witnessed it in their parents, they're going to be more at risk for not leaving a situation where it becomes evident in their adult life. Okay. So here's what we know about the perpetrators. From a socioeconomic standpoint, these tend to be partners with lower income, lower education, and lower assertiveness. And one of the things that we've seen, we saw this a bit recently with the insurrection, that a lot of these white supremacists tend to be individuals of lower socioeconomic status. And one of the psychological theories about why those individuals tend to be more sexist and more racist is a psychological need to be able to look down on groups, look down on others to make themselves feel better. If that makes some sense. Yeah, that kind of like, you know, I need to feel more powerful. So who can I hate and look down upon? And again, some of the psychological roots of racism definitely fit into that. Sexism fits into that. And you all kind of know the kind of the saying that the boss yells at the worker goes home and yells at the wife screams at the kids, and then the kids kick the dog or something like that. It's just like everybody needing somebody lower than them to take their stuff out on. Okay. From a psychopathology standpoint, we've kind of already mentioned this. These individuals are more likely to be engaged in alcohol and drug abuse, and that's going to do lots of things. It's going to make them more impulsive. It's going to impair their frontal lobe's ability to inhibit their emotions and inhibit their irritability and inhibit their tendency to be violent to somebody else. It's going to create more chaos. It's going to create more financial stress. So there could be a lot going on with the alcohol and the drug abuse there. More likely to have borderline and antisocial personalities, more likely to have anxiety and depression. But again, evidence, all of this kind of stuff, we talked about externalizing disorders in men compared to the internalizing disorders in women when we talked about feminine gender role stress. More likely in men to take their distress out in anger towards other people. That it's more acceptable for men to kind of show anger than to show vulnerability in other ways, unfortunately. In terms of aggression, the physical link tends to be associated with the sexual aggression. And those that harm their partners tend to also harm their children. And I have known women where they've tried to draw the line between it's okay if he comes after me, but if he comes after my kids, I'm out of here. So this is what we know about the perpetrators. Okay, lots and lots and lots of medical and psychological consequences. And for those of you who are going to be a future healthcare provider, let this sink in, because this is going to be important in your future. Women who are victims of domestic violence are a lot more likely to frequent the emergency department of a hospital. They are more likely to have facial injuries. And again, men oftentimes know that women have appearance concerns and go after their face to deliberately know that that's going to feel harsher for a lot of women than going after different body parts. They are 13 times more likely to have injuries in their chest, their breasts, and their abdomen. And they're more likely to have multiple injuries in varied stages of healing. Okay, does that make some sense? So it might be they go in for a broken arm, let's say, and they've got a new break, and then you can see on the x-ray an old break, meaning that they are repetitively getting injured, and that is unusual. I still remember when my boys were little, I just got to tell the pediatrician story here. When they were little, the pediatrician wanted to raise their pant legs and look for bruises. And I still remember asking Dr. Horn, late Dr. Horn, he raised their legs and looked for bruises, and they had a bunch of bruises. And I said, is this what you do to screen for domestic violence? And he corrected me. He's like, oh no, if they don't have bruises on their legs, they're not active enough. And my guys had lots of bruises on their legs because they were very, very physically active, kind of hyperactive and that type of thing. But then I still remember Dr. Horn saying, when it's domestic violence with kids, I'm more likely to see bruises on their arms where parents are grabbing them, where the parents are grabbing them and shaking them. And it was like, oh yeah. My kids had bruises all over their legs, but none on their arms, as an example. Okay, but But anyways, okay. Lots and lots of use for these women in primary care. So they're frequent flyers to healthcare, frequent flyers to primary care, frequent flyers to emergency departments. From a healthcare perspective, that gives us professionals lots of opportunities to intervene and help these women and help these families. Okay. But a lot of physicians and healthcare providers are scared of this, and they're afraid to ask. And if they haven't been adequately trained on how to intervene, and they don't want to get pulled into it, they don't want the perpetrator coming after them, there are lots and lots of reasons to be scared, which is why we need to have the right kind of training so that individuals know how to ask the right questions and how to intervene in a way that is protecting them as a professional, how to intervene in a way that best protects a woman and any children if they're children in the home. Okay, so this can be overcome. Lots of negative pregnancy outcomes, more likely to seek abortions, more likely to have a stillbirth if that baby has died, whether it's been injured or the mom has been injured in such a way that it has harmed her ability to carry that baby and keep that baby alive. More likely to have low birth weight babies, which tend to be defined as a baby full term under 5.5 pounds. So malnourished or injured in utero. The negative health consequences, these women are more likely to struggle with eating disorders, their own substance abuse as a coping mechanism, riskier sexual behaviors, more depression and anxiety, and more post-traumatic stress disorder. But even within the PTSD category, we know that there's some predictors of getting PTSD versus some of the women who are resilient and do not develop PTSD. The more the severity of the violence and the more recent the violence was, the more likely PTSD. The more life threats that are made, so the intimidation and the threatening that can go on, like if you do this, or if you tell anybody I'm going to kill you or I'm going to kill the kids, those kinds of threats hit home. Women with less personal resources, that makes some sense. And then women with low social support, particularly if they have been controlled and isolated. So not having family who can come and help them and get them out of there, that type of thing. And if you look at some of these kinds of things, you definitely see a lot of this exacerbated in rural areas. Thoughts, questions here? Okay, so interventions for violence, medical and psychological screening. This would be how to, just one component of training a healthcare professional in how to ask questions and how to begin intervening, okay? And I was trained, if I were seeing somebody who had an injury, not to ask, how did this happen to you? Because you will get stories. Oh, I tripped and fell down the stairs, or I'm just so clumsy. That's why, I have an old break in my arm and a new break in my arm. I was trained that the healthcare provider looks her in the eyes and says, who did this to you? Okay, who did this to you? And that's much more likely to free up a woman to say, my boyfriend, my husband, my female partner, that's who did this to me, okay? And then the discussion can ensue on, okay, what's been tried in the past and how to intervene, how to hook up this woman with different resources. So like locally, if I had a client come into my private practice and was a victim of domestic violence, I would make sure, well, we do safety planning, all kinds of other stuff, but I would make sure they knew about OASIS and the resources that OASIS can offer them, helping them with healthcare, helping them with childcare, providing them with hidden shelter if needed, providing them with free legal aid if needed. OASIS has got it all. So getting them to the appropriate resources. Recently, Emma knows this story, but recently I was out here watching TV in the dark one night, and I have a big 100-pound black German Shepherd dog, and he and I were cozy on the couch watching TV. I go off to the bathroom. So I'm gone like less than a minute to the bathroom. I come walking back through in the dark. He has moved. My dog moved from the couch and was now lying in the floor. My black dog in the dark, lying in the floor in my path back to the couch to watch more TV. And I trip over him. I trip over Leo, and I land on my chin and bust open my chin. Okay. The next day I go to urgent care, and I didn't need stitches. They ended up gluing me, and I kept waiting for them to ask me, who did this to you? I was just ready for that question, like, who did this to you? And I was going to, at that point in time, I was going to say, well, me, I tripped over my dog. I guess he's sort of to blame, but it was my fault, walking around the house in the dark, that type of thing. But if it had been a partner who had busted open my chin, I would have appreciated the look in the eyes and somebody's asking, who did this to you? Okay. So I was disappointed in urgent care for not doing that. They had an opportunity to potentially intervene, and I hope they don't let other women and children or people who are accessing their care because of domestic violence or letting them slip through the cracks. Okay. Encourage a safety plan, either how to get to a shelter. Again, we talked about packing the bag, keeping an extra cell phone somewhere, like a burner phone, in case your cell phone's been taken away from you and you need to contact individuals or call 911. It's very important when we are interviewing a woman who's been a victim of domestic violence to inquire about children in the home and if they have been victims from the perpetrator, because that requires legal reporting. Like any healthcare provider has to report that if children are in the home under the age of 18 and they have experienced any type of abuse. When it's an adult woman, we don't have to report that to anybody. We simply work with her and her options and try to empower her to make her own decisions. But when it's kids involved, and or the law usually applies to elderly who are incompetent to take care of themselves, or elderly who are in need of care from others, that oftentimes, depending on the state, requires reporting to the Department of Social Services. Okay. And that's hard for people to do until they get used to that reporting, because the fear is if they report and Department of Social Services comes and investigates, violence might increase. And sometimes that is the case. But in a lot of situations, children need to be protected and pulled from the home. Mom and children might need to be pulled from the home. In a lot of situations, whoever is sexually or physically perpetrating those kids is doing the same thing to other kids. So sometimes it's not just about the intact home and intact family, it's about other individuals. So it's absolutely obligatory to report that type of thing. I've been trained, and most healthcare providers are trained to do lots of documentation with these kinds of cases. And documentation would be, as a healthcare provider, we should always be documenting with HIPAA protected notes for whatever, the diagnosis is and whatever our treatment is, that type of thing. But document in case a court system subpoenas those records. Not only have you clearly documented the reported abuse and violence towards that woman, you have also legally protected yourself as a healthcare provider in stating what you asked and what you assessed and what you did to intervene. Okay. So it would be unacceptable. Let's say I'm a physician, which I'm not, and I had a woman in who was injured. She busted her chin open or whatever. And let's say I report the injury in my notes, and I report the stitches, and maybe I report the prescribing the antibiotic. But I did not, in my documentation, say I assessed for domestic violence, and I did not intervene. What if she leaves my office and that evening she gets murdered? Y'all with me? So it's not only a professional means of potentially helping the victim in the future, but it is also our ethical obligation to practice appropriately, if that makes sense. Okay. When it comes to support and psychotherapy, there's a rule of thumb here. Couples therapy is not recommended. When there is ongoing domestic violence, a therapist should not invite two partners in to do therapy. They're going to be asked to take sides. There's going to be lying going on. There sometimes is an increase in violence if the woman is able to voice her concerns publicly. Individual therapy is, but it is not a way of fixing violent behavior by doing couples therapy. That makes sense. And it would be quite dangerous to the healthcare provider also. Okay. You don't want to be seen as taking her side, because then oftentimes he's going to come after, he or she, depending on the partnership, is going to come after you. That makes some sense? Can you see why healthcare providers are scared? Does it make some sense why they're scared, and why appropriate training needs to be offered, as well as in a healthcare system, not only the training, but the ability to rely in supervision on professionals who are more experienced than, say, a newbie, and walked through it and shadowed and being able to kind of process that kind of stuff with more experienced practitioners. And then offering legal consultation or legal action. And again, I know Oasis, if women can't afford that, they know how to get free legal advice for them. So things like getting a restraining order, or in really, really severe cases, helping individuals change their escape, travel, and change their identity. So like a witness protection program kind of thing. Comments, questions here?
I have a question.
Okay.
So I don't know. I was wondering if there's any type of like almost minimum doctor visits that like raise red flags to people, like if they have a certain number of doctor visits a year for like injuries. Because I know when I was a kid, I was really clumsy and I had to go to the emergency room 3 times in 1 year. And they told my mom that if I had to come in like one more time, they were going to have to like file a report with DSS. So I don't know if there's like a number or like anything like that that like raises a red flag with like healthcare providers for women.
There probably are norms that are used or cutoffs that are used, where it starts to raise a red flag. Yeah, so if you had multiple injuries, I could see that at some point being like, is she getting injured tripping over her dog, or playing softball or that type of thing, or is she a victim of violence in the home? I know with primary care and emergency departments, they see, not only do they see injuries, they see a lot of somatic complaints. So women that keep going back with like stomach aches or fibromyalgia pain or headaches, or these somatic kind of things that are happening in their bodies, but when they run tests, they can't find the cause. And one way of thinking about that, we actually see the somatic complaining higher in rural areas, because, and not just from victims of violence, but because, I'll give you an example. So let's say I'm a local in this rural area. So I'm not me. And I am depressed, but it's not socially acceptable for me to go to a doctor and say, hey, I think I'm depressed. I'm likely going to keep going back to that doctor going, I'm having trouble sleeping, and I'm having stomach aches, and I'm having back pain. And it's more socially acceptable in rural areas to somaticize than to report psychological or emotional distress. And so therefore we see that more in these victims of violence, right? So they're going in for not only injury care, but they're going in for these somatic complaints, and they're doing so frequently. So that would be a red flag in an emergency department or a primary care practice. Yeah. Good question. Anybody else have comments or questions? So let's define rape and sexual assault. You all are college students, you're woke, I'm sure you know these definitions, but rape is non-consensual oral, anal, vaginal penetration obtained through force with threat of bodily harm when the victim is incapable of giving consent. And you all know college students tend to be trained more thoroughly than, say, individuals who do not go on to college about what consent means. And consent is defined as somebody who is sober and capable of saying yes or saying no. It's not just the opposite of not saying no. Okay, that ideally individuals are being asked, is it okay for us to do this? Is it okay for us to go further? And then there becomes a time where somewhere in a relationship, the consent is considered to be blanket consent. Some states have laws about whether or not you can accuse a partner of rape after there has been sexual activity, whether it be in a marriage or it be in a partnership. And some states do not have those laws, as an example. Hostile, forcible act aimed at dominating, degrading, or humiliating a victim. I know when it's Christine Blasey Ford, right? She was the one that testified in the Senate hearings, and she talked about what had happened to her in her attempted rape. And she talked about how there was the man on top of her and the man watching, and she was able to escape and not get raped. But she said the most horrifying thing in her memory when she testified in front of Congress, this is where she choked up, she said they were laughing at me. So like this violence is being perpetrated, somebody is witnessing this violence and they were laughing. And it's like, that's degrading and humiliating. And the predominant fear for most individuals is fear of death. So I've worked with clients who have frozen and then feel very guilty about having frozen, which is actually adaptive in a lot of situations. Some individuals will fight a bit and then stop fighting and oftentimes feel guilty about that. But if the message is there that if you don't let me do this to you, I will get violent and harm you worse, then it makes a lot of sense that a lot of women freeze and let it be over with instead of trying to fight back. There's also this, sometimes it's called a moral wound, but I've also worked with individuals where it wasn't so much that because of the event, they thought they were going to get killed, but this psychological or this moral wound of knowing I will never be the same. Life will never be the same. And fitting with the social psychological phenomena called a just world hypothesis. In a just world, when people are harmed, they deserve it. And what happens, I've got a current client that I've been seeing for a while who's going through this. When the bottom drops out and this happens to an individual, this unspeakable, unthinkable thing, this horrible thing happens to them, there's now a brand new fear in living life of if it happened to me once, it can happen to me again. Or I will never be the same. Like I was stable and innocent and now I'm not. Now I'm damaged goods. And I can tell you from a therapeutic standpoint, I mean, we get in there, we work on that stuff, the self-blame, the damaged goods, but it is challenging because that stuff can get so ingrained in some individuals, which is very sad. Thoughts, questions, comments? Okay, types of rape. Stranger rape, and we're going to talk a little bit down here about blitz rape or rape with a weapon, is less common than acquaintance or partner rape. But I do want to spend a moment talking about acquaintance rape. And you all know that term, much more likely to be victimized by somebody that we know than some stranger jumping out of the bushes and attacking this kind of thing. However, I attended a training on interpersonal violence, and there's a sociologist who studies I don't know, it's not gang rape, but it's when men work together with other men in order to rape women. And the example that this sociologist particularly studies is the behavior in fraternity houses and what goes down in fraternity parties. And the one thing that I learned that had not really registered before was how often these acquaintances are not just like, oh, he's a friend of my friend, and that's how I'm acquainted with him. Many of these acquaintances are deliberately perpetrating, deliberately making the acquaintances, if that makes sense, deliberately targeting. So as an example, one of the sick things I learned is a lot of these fraternities, these guys get out there on campus and they deliberately target first semester women, freshman women, or first semester women, and then flatter them, flirt and flatter them, and then invite them to a fraternity party that these women go to, and then deliberately drug or alcohol them, and then deliberately figure out how to get them alone and rape them. And so in those situations, it's not like an acquaintance, like a friend of a friend, it's deliberately targeting women. And that is sickening to think that that goes on at times. They may, well, we talked about the drugs or alcohol or the Rohypnol. And y'all have heard about things like never leaving a drink anywhere, always keep your drink in your sight if you're drinking. Do y'all know about, this wasn't invented back when I was dating. But the nail polish that you can dip, have y'all heard about that? You can dip and it changes colors and it can tell you if there's something in the alcohol or in your drink. Marital rape tends to oftentimes happen on the continuum of violence. I worked with this woman on, this is my reminder here, this is the hospital I was working in at the time, where it took her a while to tell me that her husband was violent against her. And then it took her a while to tell me after that in his violence, he would oftentimes come home drunk and physically assault her and rape her. And then it took her even longer when I was working with her to tell me that not only did he come home drunk and physically assault her and rape her, but he would choke her. He would choke her during intercourse. And again, that threat of death, she was like, she would just kind of take it and not fight, but then that scared, she thought he's gonna accidentally kill me, he's gonna kill me at some point in time. So just kind of that continuum of what happened. The gang rape, where there's more than one perpetrator, tends to be more commonly targeting teenagers and college women, more likely to be alcohol and drug involvement, and this is more likely to get reported. Isn't it interesting that psychologically, a lot of these victims, like if it's sort of like it happened with this one guy at a fraternity party, a lot less likely to report it. But if it happened with more than one guy, more likely to report it because that seems more deliberate, if that makes sense, and less self-blame going on there. And then the blitz rape is more of a stranger attack, and there tends to be more use of a weapon and more life threat. And interestingly, this is the stuff that many women fear a lot more than this stuff, which is more likely to actually be happening to them. Victim responses, it makes a lot of sense that as a traumatic event, there would be tremendous fight or flight in a response. And one way of thinking about what happens for a lot of women in the aftermath is that all of this trauma becomes associated with certain thoughts, certain emotions, certain behaviors. This stuff can get classically, in a traumatic event, it can be classically conditioned in one triad, just like that. And one way we think that we're wired for that, and a little bit of what PTSD serves as a psychological function, is it's a reminder, an unfortunate reminder of like, whatever you were doing and whatever situation you were in, it's our bodies and brains reminder, don't do that again. And so you can see where the self-blame comes in also, right? But it's sort of like, whatever you were doing, stay away from that. Don't do that again. So it is meant to be functional in protecting safety after this traumatic event. But unfortunately, this becomes a life of its own. And the traditional diagnosis would be PTSD or depression in a life of its own. Unfortunately, a lot of women resort to alcohol and drugs to escape these intrusive memories. And it's a risk factor for suicide, which is a very sad thing, where again, that sort of sense of like, life will never be the same. I'm damaged goods. I can't handle this. In a lot of situations, the brain shuts down affect, like they feel numb. It's sort of like the brain shuts down. If you're going to feel bad, how about you feel nothing and feeling numb? There tends to be this thing called anhedonia. And anhedonia is the inability to get any pleasure or any reinforcement out of what one's doing. And anhedonia is a predictor of depression and PTSD, and it's a predictor of suicide or a suicide attempt. We talked about this already, the somatization, lots and lots of physical complaints. And this gets a little more psychodynamic, but I've seen this, and it actually makes some behavioral or classical conditioning to me, as well as being a psychodynamic way of thinking about it. But there are people that talk about and believe in trauma memories in the body. Okay. So as an example, a lot of women who have been victims of rape will report a lot of pelvic pain, a lot of sexual dysfunction. And again, that's where trauma, part of the body, one of the parts of the body where the trauma occurred. And it would make sense that there would now be either physical injury or a memory of pain and injury associated with different areas of the body. There tends to be a lot of anger and irritability and a lot of hypervigilance. And that hypervigilance is like, and again, PTSD, the function is to prevent you from bad things happening in the future. But the hypervigilance is this sort of like, like, oh, I can't be in the dark, and I can't be alone, and I can't lay down and relax and sleep, and I can't enjoy Netflix and watch Grey's Anatomy. And, it's just always needing to be on high alert. Because if the bottom dropped out one day, the bottom could drop out again any day. It is possible. This takes a tremendous amount of courage and work in therapy. But there are individuals, and it's called post-traumatic growth, who we can successfully treat their PTSD, and some individuals actually grow and find meaning and move beyond their traumatic experience. And let me give you an example. I did not do this work with this woman. She had done this with another therapist, but I'll tell you the story. So I see this woman, and I'm doing my intro interview, and I always ask about violence and trauma. And I ask her about, have you ever been touched? Here's how I ask it. Have you ever been touched in a way that made you feel uncomfortable? And I go with that first. And then I'll move into physical violence, and then I'll move into rape and that type of thing. Because people are oftentimes more likely to, some individuals don't even identify that they were raped, but when asked if they were touched in a way that made them feel uncomfortable, they'll tell me about a rape, if that makes sense. So this particular woman said, yeah, I was raped when I was age 22 or something like that. And I just, I said, is this something that we're going to need to talk about and deal with in our work together? And she said, oh no, I did years of therapy with a previous therapist. And then she tells me, so she had done this work. Okay, got it. And then she tells me, that man took 20 minutes of my life. He's not getting a second more. And it's like, oh, that is a great example of post-traumatic growth, right? Yeah. And then kind of like AOC, I played her at the beginning of this, she's been really brave to kind of speak out about her past, but she's a wonderful example of taking one's own trauma and using it to advocate for other individuals who are victims of trauma. You know, I like that. That is a sign of a growth, of being able to take your story and use it to try to help others. Questions here about typical responses or the post-traumatic growth aspect? Okay, I'm watching my time. The reaction of others very much matters. And we're going to talk, I've written about it in one of my book chapters, so we'll talk about it a little bit later this semester. Whoever has that chapter, make sure that we bring this up. But it's the phenomena called blaming the victim. Okay. And the blaming the victim happens all the time, and it is absolutely horrible. But there's a psychological function for people who do it. Okay. And we'll talk about that later in the semester. But positive support is very important for victims of any of this kind of traumatic events in their own recovery. Oftentimes a really sad thing happens where if there is a partner and this individual gets perpetrated by somebody else, partner withdrawing, partner either blaming the perpetrator and wanting to kill the perpetrator, or partner blaming the woman. You know, you shouldn't have had that drink. You shouldn't have had a girls' night with your friends. You shouldn't have been in that parking lot in the dark. You shouldn't, that kind of stuff. That is really, really harmful. And we call that second victimization. And so when I've worked with clients who wish to disclose what happened to them to whomever, and then sometimes I've worked with clients who want to go back and confront a perpetrator in hopes of getting an apology, in hopes of getting acknowledgement, and in hopes of getting an apology. Oh boy, do I get in there and spend some time on that. Because for a lot of individuals, that's very wishful thinking. Like, you're going to confront a perpetrator in your past, and that person's going to be like, oh yes, that happened, and I'm so sorry. That is not how that oftentimes would go down. So spending time with them, helping them think through, who do you feel safe with? Who can you disclose this to that you are pretty confident is going to believe you, support you, not blame you? Okay. That is really harmful when victims of violence do that and somebody blames or is just not support, or doesn't believe them. Or like that, you know, Uncle Joe would never do that. I don't believe you. You're making it up. You're trying to get attention, that kind of stuff. Really damaging, second victimization. Self-blame runs really, really, really deep. And again, from that PTSD function, I get that. I understand it. But it can run so deep, and we know there's even a self-blame scale for victims. And the more self-blame is there, the worse the PTSD or depression, the more likely the suicide attempt, and the more likely this person is not going to get past this and reach a state of stability and growth. Okay, so the self-blame is very pernicious, very harmful. And then we get, and I've worked with couples with this, is really, really sad. A lot of times you have to do, if the partner is willing to stay in the relationship, you have to almost do some sex therapy with them, because a lot of times the individual who's been the victim of this trauma is going to have sexual dysfunction, trust issues, touch issues, issues with arousal, issues with reaching orgasm. Touch and all that kind of stuff could be re-triggering the traumatic event. And so not only can it play itself out in what's happened to the victim, but it can play itself out, unfortunately, in a loving partnership after she's been a victim of violence. Medical care, ideally an individual is taking quotes of what happened and documenting that in their healthcare notes. They are assessing all the sites of trauma and treating sites of trauma. This would be really hard, I would think, to endure, but oftentimes they have to take photos of all of the injuries, and so there's documentation of the injuries. They should be offered a rape kit to search for evidence, search for pubic hair, search for semen, search for skin, any kind of DNA evidence that they can collect under fingernails and vagina, external on vulva, anywhere that they can get that evidence. I had a client at one point in time who was raped in Wilkesboro, and she went to an ER, and the emergency room treating physician refused to give her a rape kit and refused to give her a day after Plan B pill to prevent pregnancy. And it's just like, somebody report him to the medical board because that is not compassionate care. Ideally, they're taking cultures for sexually transmitted diseases, but keep in mind, if this is immediately post-rape, a lot of times good healthcare is recommending that individuals come back for continued STD screening, because some STDs are not going to show up immediately after exposure. They're going to show up after time to incubate. Blood tests for STDs, and again, sometimes that has to be done later in the future. Testing for pregnancy now, testing for pregnancy like 2 weeks away, that type of thing. Or simply, if she wants Plan B, giving her Plan B so that there's no, if there is an embryo, it can't implant. So any kind of emergency contraception. And these individuals are more likely to go to primary care than to present to mental health care. So again, a good trained primary care provider is going to refer to OASIS, is going to refer to mental health care providers, because these individuals are going to need that emotional, psychological support. Okay. All right, I know this has been a tough material, tough lecture. Anybody have any comments or any questions? Note that I have office hours this afternoon, 2 to 5. So if anybody wants to talk, if any of this was disturbing, you want to talk about it, or you just want to talk about it like as a future healthcare professional, note that I will be hanging out in my office hours. You can come and visit me. Okay. All right, next class, we will cover common psychological disorders for women. Okay, take care. Good to see everybody.
Thank you.
Bye. Take care.